Okay, so before we jump into panniculitis, just as a continuation of what from the vascular diseases, I just want to cover a few concepts regarding calciphylaxis and monkeybird's medial calcific sclerosis. So okay, so this is kind of like a common board question that they like to test you on. Is monkeybird's medial calcific sclerosis. So this entity presents with, calcium deposition involving the tunica media, and it's just an incidental finding which is seen in elderly patients with atherosclerotic peripheral vascular disease, and it's got nothing to do with calciphylaxis. So you have this concentric calcification of vessels, and pretty much the rest of the skin will look essentially normal. So there is no evidence of any kind of a tissue necrosis or destruction. So that's monkeybird's medial calcific sclerosis. Now, this is going to be in contrast to calciphylaxis, wherein you actually get evidence of ischemic tissue necrosis. So, as we talked about in vascular diseases, whenever you see a pale-looking epidermis with this outlined cells where the pallor of the nuclei is lost, that's indicative of an ischemic tissue damage as seen in coagulative tissue necrosis, indicating ischemia. And in calciphylaxis, the skin really doesn't look healthy at all. And we went through a few examples even in our study set. And as you can see in here, there is evidence of both epidermal and dermal necrosis. Often the tissue in the background has this kind of a basophilia, and this is because of calcium deposition in the background. And a very important clue is to identify the dead fat, so the necrotic fat. This is very unhealthy looking. There is ischemic damage. Besides seeing the calcium deposition in the walls of the vessels, you're seeing calcium in the tissue itself. So this is all part of calciphylaxis. So that's an important board question. Okay, so now let's jump right away into panniculitis. So this is an important slide wherein whenever we are talking about panniculitis, the most common cause is a septal panniculitis. And the most common cause of a septal panniculitis is enodosum. So by far, the most common panniculitis you do see is enodosum. Whenever we see, normally in normal skin, you do not see the septum. If you're seeing the septum, that is a septal panniculitis. And the first two entities listed here are the two most common causes of septal panniculitis, but it's kind of like nice to remember the rest of these entities as well. So let's talk about enodosum. So as we know, enodosum is a common septal panniculitis. And as I said, in normal tissue, you do not see the septum. If you're seeing the septum with septal fibrosis and thickening, that is a septal panniculitis, which is consistent with enodosum. If you find giant cells in the septum, as you can see in over here, that is pretty much, diagnostic of enodosum. In enodosum, you do get spillover of inflammation into the adjacent lobule. So you can see that there is periseptal lobular inflammation. This would be a part and parcel of enodosum. So septal fibrosis and thickening and giant cells in the septum pretty much defines enodosum, and you can get spillover of inflammation into the adjacent periseptal lobule. So I'm going to show you some more examples. This is another example. So you can see this is a deep punch biopsy, which includes the fat, and there is thickening of the septum. So as you're following it, it's kind of like a zigzag pattern of a thickened septum. And if you see any kind of a granuloma in the septum, that is enodosum. This is going to be in contrast to your deep morphea or morphea profunda, wherein the sclerotic process will also involve the dermis. So typically in classic morphea, you get dermal sclerosis of the upper and the mid dermis, but in deep morphea, it begins in the deep dermis and extends on to the septum to produce the septal thickening, kind of producing this kind of a swollen face. So unlike enodosum, which just is in the septum, here you will see other features of morphea like entrapment of the sweat glands, loss of hair follicles, as well as no granulomatous inflammation. So this is deep morphia producing also septal fibrosis and thickening. Okay, now let's come to your lobular panniculitis. So that's the other part of the this particular part of the chart over here. So whenever we are dealing with the lobular panniculitis, the first thing we want to look at is there an associated vasculitis? And if there is an associated vasculitis, are you dealing with multiple vessels and multiple lobules, as you see in E. induratum, or is it just restricted to one vessel, one lobule, which would be seen in polyarthritis nodosa? So let's see, what exactly I'm talking regards to that. So this is an example of lobular panniculitis. So you can see here, it's a deep punch biopsy, and you have the nice fat included here. And you have multiple sections of lobules, which are kind of matted together. So in E. induratum, always when you do the biopsy, the fat kind of like falls apart. It is almost necrotic. And the background fat necrosis looks very dirty. It has a suppurative and even sometimes a granulomatous look. So you often think infectious. But there is a corresponding small vessel vasculitis with it, which could also be medium vessel. But it's multiple vessels. You can see this kind of a dirty fat necrosis with neutrophils, and there is a background vasculitis. So you can see all these unhealthy looking vessels embedded within the fat. When I'm thinking, so this is vasculitis right here. So when you see multiple vessels, multiple lobules, kind of like a dirty looking lobular panniculitis, you think about E. induratum. Let me show you another example. Now, E. induratum, when I look at E. induratum, I think about that this is almost like kind of an id reaction occurring to a distant focus of infection. The most common focus of infection is latent tuberculosis. So even though these you can see how dirty the lobular fat necrosis looks like. You can see it's very neutrophilic and suppurative, and there is corresponding multiple vessel, multiple lobule panniculitis. Even though these lesions look pretty dirty and infectious, they're actually sterile. So you will not be able to culture any bacteria, including mycobacterium, from these lesions. PCR analysis may yield something, but it's very uncommon that these lesions harbor the bacteria. It's a distant focus of tuberculous infection. So, you have to do things like quantiferon TB ELISA assay or chest X-ray or PPD to be able to detect latent TB infection. Hep C is another cause, or it may just occur as an id reactive phenomenon secondary to an acute bacterial infection that the patient has had. So, but the important thing is multiple lobules are being involved. There is dirty fat necrosis, and there is multiple vessel involvement. Now, this is going to be in contrast to your cutaneous polyarthritis nodosa, which is going to be one vessel, one lobule. And you typically don't have a problem recognizing it because there is one medium vessel vasculitis, which is involving one corresponding lobule. So one medium vessel vasculitis with one corresponding lobule, and the background lobule doesn't look dirty like the way it looks in E. induratum. Now, cutaneous PAN, there is nothing in the biopsy itself which will tell you that whether this is just isolated cutaneous polyarthritis nodosa or whether this is a part of a much more systemic disease in which the patient has systemic ANCA-mediated vasculitis, like microscopic polyangiitis or even Wegener's disease. So the necessary workup will be required, including hepatitis B and C serologies, as well as renal function tests. So there's nothing in the biopsy itself which will tell you whether this is just cutaneous or is it a part of a systemic disease process. But you can see that it can be very easily distinguished from E. induratum because of the clean nature of the lobules and one vessel, one lobule involvement. Okay, so now let's come to the second part of the slide. When the vasculitis is absent, then what you do with the panniculitis. Look at the color, whether it's distinctly pink or has a dirty background to it with an amphophilic tinge. When it's pink, you are dealing with either lupus panniculitis or lupus profundus, or you're dealing with sclerosing panniculitis. So let's talk about that. Lupus profundus. So lupus profundus, these lesions most commonly involve middle-aged females. They often give a history of preceding trauma, but the lesions, have got nothing to do with trauma. They are papillovillaceous plaques or nodules occurring on any part of the body, most commonly the upper extremities, but certainly the head and neck, trunk, lower extremities can also be involved. Many of these patients have underlying lupus, mostly discoid lupus in 40% of cases, but it can also be systemic lupus. Interestingly, the overlying epidermis may not show the findings of classic lupus. So you may not see the chronic interface change with the thickening of the basement membrane. Mucin is often detected, but it may also be absent. The classic finding is obviously a lobular panniculitis with this beautiful hyalinized fat necrosis. So you can see this dead necrotic fat with lots of pink fat necrosis, as you can see in here. This is almost always accompanied with a dense superficial deep perivascular lymphocytic infiltrate. So the background looks very lupus-like with dense superficial deep lymphocytic infiltrate. And the inflammation can be so prominent that it can even result in reactive lymphoid hyperplasia with germinal centers. So this kind of a hyalinized pink fat necrosis. Now, notice another thing. It's very important whenever you're diagnosing lupus panniculitis or thinking about it, you have to make sure that you're not missing a lymphoma, which is subcutaneous panniculitis like T-cell lymphoma. Lesions of lupus profundus and subcutaneous panniculitis like T-cell lymphoma can sometimes be present in a spectrum. So we always have to think about, let's not miss a lymphoma. And the finding of brimming of adipocytes, which I'm going to talk about when I talk about subcutaneous panniculitis like T-cell lymphoma, can also be seen in lupus profundus. So you can see that there is some partial incomplete rimming of lymphocytes around the adipocytes, but it's certainly not back-to-back or involving all the lobules. It's very focal. Also, there is background atypia, which is absent, whereas in the lymphoma, it would be atypical lymphocytes. Also, the background inflammatory cells have plasma cells in them. So you can find plasma cells in the background, and plasma cells are not seen in panniculitis like T-cell lymphoma. They would be more commonly seen in lupus profundus. So the absence of atypia and presence of plasma cells, even though you're seeing focal rimming, will distinguish it from the panniculitis like T-cell lymphoma. Another important finding is the classic hyalinized fat necrosis. So this hyalinized pink fat necrosis is very specific for lupus profundus. You do not see that in subcutaneous panniculitis like T-cell lymphoma. In subcutaneous panniculitis like T-cell lymphoma, if you do have fat necrosis, that's dirty fat necrosis. So it will produce you dead cells with suppuration, and it looks very dirty as compared to this clean hyalinized fat necrosis of lupus profundus. Also in lupus profundus, as I mentioned, you always have an accompanying dense superficial deep lymphocytic infiltrate, which is not going to be present in panniculitis like T-cell lymphoma. That typically has an uninvolved dermis. So we'll talk about panniculitis like T-cell lymphoma again, but these can be the distinguishing features. The next one is going to be your sclerosing panniculitis. So first of all, it's important to remember all the names of this disease. So sclerosing panniculitis or lipodermatosclerosis or hypodermitis sclerodermiformis. So all these names are synonymous. So you use three names: sclerosing panniculitis or lipodermatosclerosis or hypodermitis sclerodermiformis. So all these three names refer to the same disease. Sclerosing panniculitis is an entity which is caused by chronic venous stasis, chronic venous ischemia, and chronic venous insufficiency. So what you see is, again, a pink fat necrosis, but unlike lupus profundus, this does not have inflammation. So you can see it's very pauci-inflammatory. And also because the cause here is venous ischemia, so the fat is getting ischemic and dying, right? So you will see variably sized fatty spaces indicative of ischemia. And you get this beautiful membranocystic fat necrosis, wherein you see the fat of varying sizes and shapes, and this kind of feathery degeneration in the fatty cells. So you can see these nice feathers protruding in the fatty cells. This is very classic for sclerosing panniculitis. If you do see some inflammation, you often see xanthomatized foamy histiocytes, which are phagocytosing this destroyed fat. And the background has chronic blood and hemosiderin, as you see in here. So hemosiderin can be present because, again, the cause is ischemia. Now, even though this is associated with stasis change may not be seen in the overlying skin. Most often, we do not see evidence of stasis change. So that needs to be remembered. So this is lipodermatosclerosis or sclerosing panniculitis, wherein you see the nice membranocystic fat necrosis, and this is the feathery degeneration you're looking for. So let me show you another example. This is another example of membranocystic fat necrosis. So you can again see there is nice variably sized cystic spaces. And this is the beautiful feathery degeneration again with the membranocystic change and no inflammation. So that's lipodermatosclerosis or sclerosing panniculitis or hypodermitis sclerodermiformis. This particular biopsy has evidence of overlying stasis change, but I said that, this may not be seen in every entity. Okay, now let's come to some specific panniculitis. And the first among them is pancreatic panniculitis. So pancreatic panniculitis is kind of like an important entity not to miss. You can definitely, it's a life-threatening emergency, so it's necessary to pick it up. The cause here is panniculitis, which could be insidious, and the patient releases amylases and lipases, which will cause the fat saponification, causing it to release the calcium and cause fat necrosis. So what you're going to see again here is a suppurative panniculitis. So the panniculitis has lots of neutrophils, so it looks very dirty. But the classic finding is basophilia. So you see that there is an amphiphilic tinge to the fat necrosis. This is because of the fat saponification and the released calcium. And you see ghost adipocytes. So ghost adipocytes with the bluish tinge of the fat necrosis. So you can see the nice ghost adipocytes with this bluish fat necrosis. So this is classic of pancreatic panniculitis. You can see the nice ghost adipocytes and this bluish fat necrosis. So this is pancreatic panniculitis. Other specific kind of panniculitis that we deal with is your subcutaneous fat necrosis of the newborn. Now, this occurs in preterm, premature, hypoxic infants. So the first thing is that there is minimal dermis because this is an infant, so the dermis is not very well formed. And you see a lobular panniculitis wherein you see the affected lobules show these precipitated needle-shaped triglyceride crystals. So you can see the nice needle-shaped triglyceride crystals in subcutaneous fat necrosis of newborn. If you've seen it once, you will always remember it. Some of the second-order questions that they like to ask you is, so they will show you a slide of subcutaneous fat necrosis of newborn and then ask you a second-order question, like what is a metabolic abnormality with this disease? And that would be hypercalcemia or hyperlipidemia. So you need to know the associations with subcutaneous fat necrosis of the newborn. Scleroma neonatorum is a very serious condition, which again occurs in preterm infants, which are almost in an ICU setting. So these are pretty sick kids who have other underlying conditions like sepsis or dehydration or some kind of a cardiopulmonary abnormality or intestinal obstruction. And these rarely ever get biopsied. It's more of a clinical diagnosis. But the skin becomes very thick. And if you were to biopsy the subcutaneous tissue in these patients, you would not get the florid lobular panniculitis as what you see in subcutaneous fat necrosis of newborn, but you will in fact get septal fibrosis, some kind of an atrophy, and only some adipocytic lobules may show the precipitated triglyceride crystals. So the histology has been a board question in the past before, so you should know how it differs from subcutaneous fat necrosis of the newborn. Okay, so this is the classic histology of subcutaneous fat necrosis, the precipitated triglyceride crystals. Let's come to some non-discrete forms of panniculitis. So we have traumatic fat necrosis, traumatic panniculitis. Traumatic panniculitis is both septal and lobular. So it doesn't, specifically is not like contained in one particular category. So you will often see septal fibrosis along with scar, and you will see these variably sized, again, fatty lobules again. There is, variably sized cystic spaces. There is accompanying hemorrhage, some granulation tissue formation. You often see xanthomatized histiocytes, and the foamy histiocytes are again trying to phagocytose these dead adipocytes, and you see chronic hemosiderin in blood. Areas of lobular, of traumatic panniculitis can also have this kind of a tissue culture granulation tissue like what you would see in nodular fasciitis. So it's a very reactive process, which is not like really confined in one disease category. So you can see here reactive fibroblastic proliferation, very variably sized fatty droplets. So that is your lobular traumatic panniculitis. One specific kind of traumatic panniculitis which they like to test on is the silicone granuloma, and we have talked about this. It produces the classic Swiss cheese appearance. So you can see these variably shaped fat-like droplets due to the silicone within it, and then you can see the background granulomatous inflammation. The Swiss cheese pattern is very classic for a silicone granuloma. One specific kind of traumatic panniculitis which can be asked is a paraphenoma or a sclerosing lipogranuloma. Now, paraphenoma or sclerosing lipogranuloma can be very, very subtle, and it's something that you guys can probably easily miss. It presents with these very empty spaces, which are variably sized in the dermis. So you can see these very variably sized fat-like droplets in the dermis. And these have been formed by some kind of a foreign material, which is hydrophobic. So it leaves behind these empty spaces. So even though you do not see the foreign material, but you see these empty spaces in the fat in the dermis with associated granulomatous inflammation. And this kind of a reaction, it can be basically be mistaken for even a malignancy, like some kind of a liposarcoma, because it looks like fat, but it's not really fat, or even for your lepromatous leprosy. But in lepromatous leprosy, also you have these empty spaces in the dermis, but the empty spaces are histiocytes containing clusters of the bacteria, which are your fluffy bacteria, which are your globoid cells. So when we did granulomatous diseases, we talked about that. These are going to be just empty droplets of like really fat-like cells present in the dermis, associated with a minimal inflammatory response, but some degree of granulomatous inflammation. So that is your paraphenoma or sclerosing lipogranuloma. You can see all these tiny fat-like droplets present in the dermis. So that's your paraphenoma or sclerosing lipogranuloma. Okay. Then lastly, I want to talk about, a very important cause of lobular panniculitis, which is subcutaneous panniculitis like T-cell lymphoma. We'll talk about this more when we are also doing your lymphomas, but just to talk about this, this particular lymphoma is a T-cell lymphoma, which occurs more commonly again in females around the 4th, 5th decade of life. And clinically, with patients with subcutaneous panniculitis like T-cell lymphoma, they present with the panniculitis. So they present with panniculitis mimicking E. nodosum or E. induratum or lupus profundus. And again, any part of the body can be affected. Most commonly are the extremities, but any part of the body can be affected. 50% of these patients will have type B symptoms like fever, night sweats, and weight loss. And 20% of these patients will be very sick when they are presenting because of hemophagocytic syndrome. But hemophagocytic syndrome is the most common cause of death in these patients and occurs mostly in the late stage of the disease. So many patients will not develop it, but in some patients, it may be the first presenting manifestation. In 20% of patients, this lymphoma is associated with underlying autoimmune disease, and particularly lupus. And as I mentioned, that there is a lot of similarity or in a spectrum of the histology of lupus profundus and subcutaneous panniculitis like T-cell lymphoma. But remember, in lupus profundus, we saw that the background skin had a lot of lupus-like infiltrate, the dense infiltrate. You can see here that the dermis is absolutely clear over here. So there is no accompanying lymphocytic infiltrate. Also, the fat does not show hyalinized fat necrosis. And there is clearly atypia of the lymphocytes. You can see that there is marked atypia. There's some mitosis, debris, apoptosis, and there is back-to-back rimming of the adipocytes. So this is the rimming phenomenon wherein the lymphocytes, which are the lymphoma cells, they will line up the fatty cells. So you can see the beautiful rimming. So this is subcutaneous panniculitis like T-cell lymphoma. And it is absolutely important to remember the immunophenotype of these cells. These cells are positive for T-cell markers like CD3 and CD8. And because they express CD8, they're going to be positive for TI1, granzyme, and perforin. Now, whenever we are diagnosing subcutaneous panniculitis like T-cell lymphoma, it is absolutely essential that we do not miss a more aggressive lymphoma, which can also look like this, which is cutaneous gamma delta T-cell lymphoma. So that is why we stain these cells up with markers like TCR beta or beta F1. So beta F1 is positive in subcutaneous panniculitis like T-cell lymphoma, whereas TCR gamma delta is positive in gamma delta T-cell lymphoma. So those markers are extremely important, both for practical purposes and even for your derm path both. So beta F1 positivity is in subcutaneous panniculitis like T-cell lymphoma, and gamma delta positivity is in cutaneous gamma delta T-cell lymphoma. So those are the second order questions that they like to ask you with it. Lastly, there is one other miscellaneous panniculitis, which is alpha-1 antitrypsin enzyme deficiency. This is extremely rare. I've never seen a case of it. It is a neutrophilic panniculitis or pure neutrophilic panniculitis. So lobular panniculitis, which has a lot of neutrophils, and then the neutrophils are kind of like vertically oriented and thrown off from the skin by forming a tract in the dermis. So vertical orientation of the neutrophilic infiltrate with pure neutrophilic panniculitis is seen in alpha-1 antitrypsin enzyme deficiency. So do you guys have any questions?
I don't think so. That's all great.
Okay. So that was with panniculitis. So we covered panniculitis, and these are all the board questions that are asked. So next time when we will do the slides, I want you to remember this. We talked about calcifilaxis, E. nodosum, E. induratum, PAN, lupus panniculitis, subcutaneous panniculitis, T-cell lymphoma, lipodermatosclerosis, pancreatic panniculitis, subcutaneous fat necrosis, traumatic fat necrosis, silicone granuloma, paraphenoma. And then we talked about alpha-1 antitrypsin. Now, superficial thrombophlebitis, Mondo's or Berger's disease, unlikely is going to be a board question. This is going to be a large vessel, which will kind of show inflammation and destruction as you're seeing in here. How do you distinguish it from polyarthritis nodosa? Basically, it can be difficult in terms of the clinical, in terms of histology. It can look very much like PAN, but this one is in real life, we would basically like stain it. We would stain it up with like the VVG elastin stain and a smooth muscle actin stain, SMA stain, to look at the architecture of the lesion, because the vein produces a different pattern of destruction with these stains as compared to a medium vessel like in polyarthritis nodosa. But for your board purposes, these are going to be much more larger vessels, and the degree of inflammation around it is going to be more prominent as what you see in polyarthritis nodosa. But most importantly, I think they will give you some second order question with it, which will help you to suggest that this is Mondo's or Berger's disease. Berger's disease, thromboangiitis obliterans, and it could look very much similar like Mondo's disease, that is thrombophlebitis. Okay. So
Quick
now
question.
let's come.
Hello?
Yes, go ahead.
Earlier you were talking about something with latent TB, and I think comparing it to E. induratum. What was the distinction?
Say that again. Say the question again.
Sorry, you were comparing latent TB and E. induratum.
Oh, what I said is that E. induratum, the most common cause of it is latent TB.
Got it. Okay.
Even though when you look at the biopsy of E. induratum, the background lobular panniculitis looks very infectious because it's suppurative, it's dirty, there is secondary vasculitis with it, but those lesions are culture negative. So even though they look what you would see in an infectious panniculitis, they're always culture negative. So you can culture them, you can do the special stains, they're never going to grow the bacteria. They are associated, it's almost like an id reaction occurring to a distant focus of infection. And that most common is latent TB infection, which you can detect by doing passive studies like quantiferon TB ELISA assay or positive checks, actually some evidence of an old TB. Those lesions per se are sterile.
Got it. Thanks so much.
Yes. Okay, so now let's talk about the deposition diseases. So this is the next topic. So I'm going to cover the blue deposition diseases today. So when I talk about deposition diseases, I'm referring to essentially your endogenous diseases. These are not exogenous or iatrogenic, which will be covered, in a couple of classes from now. So when we are talking about endogenous deposition diseases, we are referring to deposition of something which looks like mucin. So that is the blue deposition diseases, or something that looks like amyloid. So that's pink deposition diseases. So we'll talk about the blue deposition diseases today. And this is a chart. It is useful for you guys to remember because each one of this entity can be a board question. So blue deposition diseases, we think about diseases like pretibial myxedema and REM or plaque-like cutaneous mucinosis. And then you think about solitary lesions like myxoma, focal cutaneous mucinosis, digital mucosis, or mucocele. And then you think about, again, inflammatory diseases like papillomucinosis, lichen myxomatosis, or scleromyxedema. Very similar to scleromyxedema clinically is NSF, or nephrogenic fibrosing dermopathy. Then you have sclerodema. And then you can get secondary mucin in entities like follicular mucinosis, tumid lupus or classic lupus, dermatomyositis, GA and mucopolysaccharidosis, which is your inherited genetic disease. So let's first start with your pre-tibial mixed edema. So that is a chart that I would encourage that you guys basically remember. So in your blue deposition diseases, number one is your pre-tibial mixed edema. So one of the recognizing features of pre-tibial mixed edema is that the biopsy will show a lot of mucin. So very obvious mucin. So you see tons of mucin in the biopsy, in the dermis, in the fat, but there is minimal inflammation. So you can see that there is not much inflammation happening. So just mucin without any inflammation is pre-tibial mixed edema. On the other hand, if you see a similar degree of mucin, very easily identifiable mucin, but you see the nice perivascular lymphocytic infiltrate, which is tumid lupus-like. So nice lymphocytic infiltrate, but with lots of mucin. In the right clinical context, that's when you think about reticular erythematous mucinosis or plaque-like cutaneous mucinosis. So in REM or plaque-like cutaneous mucinosis, they have to give you some hint that this is that entity because the findings of REM can be very much tumid lupus-like. One difference is that in tumid, the mucin in REM, it tends to be much more prominent than what is in tumid lupus. It's very much pre-tibial mixed edema-like. But you can see that the type of the lymphocytic infiltrate is very much tumid lupus-like. So it's more of a clinical path correlation with this classic clinical finding, and I strongly believe that this entity is a variant of lupus erythematosus. Okay, now let's come to some of your solitary diseases or entities which can present with lots of mucin. Number one is focal cutaneous mucinosis. So focal cutaneous mucinosis is a solitary papillonodular lesion where you see lots of mucin in the dermis. And clinically, this looks like either a nevus or a BCC, and it's often an incidental finding. Myxomas can look very much like focal cutaneous mucinosis, but they can be deep-seated. They're much more mass-forming lesions. And what you see is lots of mucin, but with no atypia, no cellularity. And you see shredded collagen bundles in the background, and vessels are also present. So absence of atypia is absolutely essential for diagnosing a myxoma because, otherwise you can miss a low-grade sarcoma like a myxofibrosarcoma if there is any atypia. So mucin, which is forming with these shredded collagen bundles, is a classic finding. Myxomas, remember, can be associated with Carney syndrome. So that's something that you need to remember. Next, coming to your digital mucus cyst. In a digital mucus cyst, sorry, that's a myxoma again. In a digital mucus cyst or a pseudocyst, you get a bubble on the digit or the acral skin. So you see the thick skin and the space overlying the bubble or the mucinous areas has an atrophied epidermis. And you see this bubble-like space. This produces a pseudocystic space because it doesn't have an epithelial lining. I'll show you another example. So this is again a digital mucus cyst or a pseudocyst, wherein you get the nice mucin deposition on acral skin. You often have angulated fibroblasts along with the mucin deposition. And many people believe that this is a variant of ganglion cyst. So the deeper variant of a digital mucus cyst is the ganglion or a synovial cyst. So you get the nice mucin deposition. I don't think so you guys have a problem recognizing this entity. The next one is going to be a mucocele. Mucocele is a solitary lesion, again, which occurs most commonly on the lower lip. It can present in varying histologic findings. This is a classic mucocele wherein you see all the findings. You see the biopsy from the mucosa. So there is absence of granular cell layer. You see the adjacent salivary gland tissue. You see the salivary gland with the salivary duct. If you are careful in sectioning the lesion, you can also see a dilated salivary duct. And this is the problem in the lesion where the duct gets blocked and then the mucin pours out into the tissue and is walled off by this inflammatory reaction. So you can see this inflammatory reaction, which is walling off the mucin. So again, this is a pseudocystic space because there is no true epithelial lining. So that's a mucocele. Sometimes in the later stages of the disease, you just see an empty space with no distinct mucin. That's because the mucin has been phagocytosed by the histiocyte. So you don't see mucin in the space, but it is, if you were to do like a colloidal ion stain or an algin blue stain for mucin, you would see the mucin inside the histiocytes. But you can see the nice mucosal epithelium, and you can see the nice accessory salivary gland. So that's mucocele. So now let's talk about papillomucinosis or lichen myxomatosis or scleromyxedema. So all these three diseases, they share in common the histology, as well as the histology is similar, and they all have a papillary eruption. So if the papillary eruption, and if you're diagnosing papillomucinosis based on histology, you need to do a workup for these patients, and that workup has to include hepatitis C, HIV infection workup, thyroid function tests, and especially workup for paraproteinemia using serum and urine protein electrophoresis. If that papillary eruption is associated with a paraproteinemia but doesn't have the classic findings of scleromyxedema, then you call it an atypical papillomucinosis or lichen myxomatosis. If there is no paraproteinemia, it's just a papillary eruption, then that's localized papillomucinosis or lichen myxomatosis. And scleromyxedema is obviously an entity which has the classic clinical findings and the paraproteinemia. So in scleromyxedema, this is a pretty serious disease to have. You will have generalized skin thickening, like what you see in scleroderma. But unlike scleroderma, which does not involve the face, you do not get leonine facies. And unlike scleroderma, where you always have the CREST syndrome, Raynaud's phenomenon, calcifications, as well as renal involvement, you do not see that in scleromyxedema. So those are kind of like clinical things you should know for their differential. But this is a disease which is multi-system involvement, so it can also involve the internal organs. But the histology of lichen myxomatosis, papillomucinosis, scleromyxedema is all similar. So how does this particular entity look like? So let's go back to the slide of papillomucinosis. So now papillomucinosis, it can be a board question, though it's a little bit difficult entity to recognize. So, often it is accompanied with a second order question. The classic histology is of all the three diseases, papillomucinosis, lichen myxomatosis, scleromyxedema, is busyness in the dermis. And the busyness in the dermis, it's confined to the upper and the mid dermis. So it's not a very deep-seated process. So you can see a busy looking dermis. And on low power, it looks very much like granuloma annulare. But when you go on high power, the busyness in the dermis or the papule is formed because everything is increased. So you see the fibroblastic nuclei, they are increased. The fibroblastic, the nuclei are increased. There is fibrosis, there is collagen deposition, which is going to be increased. So there is nice collagen deposition, which is occurring. There is also inflammatory cells in the background. So if you notice the fibroblastic nuclei, they are arranged in different, they are very like haphazardly arranged. But most commonly, you will see that some of them are going in the east-west direction. Some of them are going in the north-south direction. So they're very randomly oriented. So this random orientation, proliferation of the fibroblastic cells, increase in the nuclei of the fibroblastic cells with collagen deposition and with this increase in the inflammatory cells. And also you get subtle mucin. So everything is increased. There's fibroblastic proliferation, there is collagen deposition, so there is thickening. That's what produces the papule. There is mucin deposition, and there is also an increase in the inflammatory infiltrate. In cases of papillomucinosis where it is associated with a paraproteinemia, sometimes you can see a monoclonal restricted plasma cell infiltrate. So if you see a lot of plasma cells in the infiltrate, we may end up doing a study like in situ hybridization to detect clonality if there is an underlying association with the paraproteinemia. So this is papillomucinosis, scleromyxedema. You can see that the entire process is in this part of the lesion, and it can be subtle. Look for everything increase. So basically fibroblasts, fibrosis, mucin, and the inflammatory cells. Now, this is going to be in contrast to nephrogenic systemic fibrosis or fibrosing dermopathy. Now, NSF or nephrogenic fibrosing dermopathy is obviously a very serious diagnosis to make. This was classically described in patients who had end-stage renal disease and received gadolinium for MRIs and then developed this fibrotic process. So if you're making this diagnosis, it sure has legal implications. So you have to be very sure of this diagnosis. The biopsy of NSF looks like morphia on like a septal fibrosis. So remember, NSF is the cause, we just talked about it, of a septal panniculitis. So the top looks like morphia and the bottom looks like enodosum. Okay. it is a deep-seated process. So it will not only involve the dermis, it also involves the fat. So the bottom looks like enodosa because you see the expanded septum, and the top looks like morphea. But unlike morphea, where you do not see fibroblastic proliferation, you just see pink collagen, right? There is deposition of collagen, but no fibroblastic proliferation. In NSF, you do see fibroblastic proliferation. So the fibroblastic nuclei are increased. And that is similar to scleromyxedema, where you also see fibroblastic proliferation, but that's a very small process. It's just localized to the upper and the mid dermis. It doesn't go deep. And nephrogenic systemic fibrosis, in contrast to scleromyxedema, does not have mucin. So there is no mucin, but there is fibrosis. And also these fibroblastic cells are going to be positive for CD34. Whereas unlike morphea, that thickened portion of the dermis actually shows absence of CD34. So those are the distinguishing features. One of the classic findings is NSF to be able to really diagnose this disease and be absolutely sure is a lollipop body. And lollipop bodies are these concentric whorl structures, which are destroyed elastin fibers, which are containing gadolinium deposition on them. So this is a lollipop body. So again, this entity can be more of like, say, a Kodachrome kind of a question. I highly doubt it will be an active slide because it's a challenging diagnosis to make. The next thing we're going to talk about is sclerodema. So we have talked a lot about a lot of diseases with similar names, so they can be confusing, and all of them are important board questions. So sclerodema. So sclerodema is similar to morphea xeroderma in the process that it produces thickening of the dermis, thick dermis. So you can see the dermis is very thick. But unlike morphea xeroderma, this is an invisible dermatosis. So when you look at it, you essentially are dealing with something that looks like a normal skin. But and also in morphea xeroderma, the space between the collagen bundles is obliterated. So you see a thick dermis and the space is obliterated. Here, the collagen bundles, you can see they're swollen and separated. So the space is kind of increased as compared to in morphea scleroderma, where you see pink collagen, obliteration of the space. And this space contains invisible mucin. So there is mucin, which can be very subtle, but you often have to do stains like colloidal iron or allicin blue to be able to detect the mucin. Most of the time, you will not be able to see the mucin. Okay, so that's sclerodema. And we know that sclerodema, the most common presentation on the upper back is in patients with diabetes. So stigmata of diabetes mellitus, so they may have chronic kidney disease, nephropathy, neuropathies, so on and so forth. But it can also have a more self-limiting disease course in kids who have had an upper respiratory infection. Or in some instances, it can also be associated with the paraproteinemia. So that's sclerodema. Okay, so now let's talk about your follicular mucinosis. So again, follicular mucinosis, we will talk more when we are dealing with mycosis fungoides, but just for completion purposes, when you see mucin in the hair follicles, that's follicular mucinosis. And when they are testing you on your boards, they are referring to follicular mucinosis, very similar to follicular tropic variant of mycosis fungoides. So you see the follicular tropism along with follicular degeneration, mucinous degeneration of the follicular epithelium. So when you see mucin in hair follicles, that's follicular mucinosis. And also remember that eosinophils are a predominant feature in follicular mucinosis. So it's not uncommon to see lots of eos. Just because you're seeing eos does not make it an arthropod assault with mucin. It is follicular mucinosis, and follicular mucinosis can have a lot of eos. And then remember, we can get secondary mucin deposition in diseases like tumid lupus. Everybody will recognize this to be a slide of tumid lupus because we have the tight lymphocytic infiltrate, very lupus-like infiltrate. And then there is background mucin. So that's tumid lupus erythematosus. And remember, this can look very much like REM, but in REM, the mucin is more prominent, but look out for a second order question associated with this. This is the stain that we often do for detecting mucin. This is the colloidal iron stain. So it will, it can be a bit, I don't really like to do this stain. I can recognize mucin on histology itself, but if they ask you, this is how it looks like. This is a colloidal iron stain, which will stain the mucin blue, but you can see it has a very high intense background staining. So sometimes it is difficult to distinguish what truly mucin is versus not. And what else am I missing? Yes, I think that was it for your mucinous, and then mucopolysaccharidosis. Mucopolysaccharidosis can also present with mucin. Remember, these are associated with your Hurler's and Hunter syndrome, and you do see. So it looks like focal cutaneous mucinosis, mucin in the dermis, right? There has to be some second order question with it, or remember the presence of metachromatic granules. So these are I've never seen a case of it, and this is something which will probably more of like an electron microscopic finding. It can be seen on histology as well, but it would be extremely difficult. I've never seen it, but this is what the books describe it as. These are metachromatic granules which are seen in the cytoplasm of fibroblasts and in the sweat glands. So that's something you should remember for mucopolysaccharidosis. Is that good?
Yeah, that's great. Thank you.
Okay, so I'm going to send you guys the study sets pertaining to panniculitis and the deposition diseases. That is going to be similar to the deposition disease. So it's either chapter 13 or 14 of Dirk Elston, and I'll send you the link for it. So we will, in the next class, we will finish. We will do the pink deposition diseases, which is literally going to take me like 10 minutes. And then we will start with those study sets.
That sounds great. Thank you so much.